Hi, my name is Mohamed Sadek, and today we'll be giving the first of a three-part lecture looking at cardiac arrhythmia mechanisms. First, we'll explore ECG foundations, then the arrhythmia mechanisms of bradycardias and tachycardias, and the final portion will be therapy of bradycardias and tachycardias. A word before we start, reading ECGs is a very important skill for every physician, whether you're a cardiologist, a family physician, pediatrician, surgeon. It's very important to recognize basic cardiac arrhythmias, and ECG is a very important test to be able to interpret. It takes a lot of practice, and I do encourage residents to always look at their patients' ECGs, whether they're normal or abnormal. If you're able to understand what a normal ECG looks like, the abnormal will become easier to recognize. It takes years to see everything, but we're going to try to cover the basic concepts in the next few hours. But like I said, if you keep an eye out for any abnormal ECGs, look at your patient's ECGs all the time, and bring any questions you have to your attending physician. Then with all that practice, hopefully you will build the skills required to learn ECG interpretation. There are exceptions to every rule, and even though we will introduce a lot of concepts today, there are always exceptions, just like anything else in medicine. Now, the heart is a muscular pump made of 4 chambers. The atriums contract first, followed by the ventricles, and the conduction system is a vital portion of the cardiac structure that coordinates chamber contraction. Everything starts in the sinus node. The sinus node sits at the junction of the right atrium and the SVC, and it exhibits automaticity, and it's what drives the normal heart rate. So things that speed up the sinus node include activity, stress, illness. All these things will lead to an increase in the depolarization rate of the sinus node. And things that slow down the sinus node include resting, sleeping, medications, etc. So the sinus node is where things usually start, and it drives the normal rate of the heart. Once the sinus node depolarizes, it conducts to the right atrium and to the left atrium in sequence, and the impulses will traverse the atria and end in the AV node, which is the junction between the atria and the ventricles, and usually the only path between the atria and the ventricles. At the AV node, there is a delay in relaying the impulse to the his Purkinje system. This delay is seen on the ECG as the PR interval, and it serves multiple important functions. The first function is it allows atrial contraction and emptying prior to ventricular contraction. So after the atria depolarize, which is seen on the P wave on the ECG, the atria depolarize, they contract, they fill the ventricles. There's a bit of a delay as the filling occurs, then the QRS begins. So the PR interval is important to allow for AV synchrony and ventricular filling of blood from the atrium. The second important function is that the AV node delays signals coming from the atria to the ventricles, especially if there's an atrial arrhythmia. So if for example, the atria go into atrial fibrillation, which is a very fast and chaotic rhythm, the ventricles will not depolarize at the same rate as the atrium because that would cause death. So this is a very important protective mechanism. So even though the atriums are going very, very fast at more than 300 beats per minute, the ventricles are only going about 100 to 140 beats per minute. So this is a very important protective mechanism, and it's called the decremental conduction property of the AV node. Following this, impulse is delayed and then conducts to the his Purkinje system, which is composed of different bundles that supply both ventricles simultaneously. So there's the left bundle, which supplies the left ventricle, and the right bundle that supplies the right ventricle. And usually the ventricles depolarize simultaneously. The his Purkinje system transverses electrical impulses quickly throughout the ventricular myocardium, and this leads to a very narrow QRS. If there's a delay in a portion or all of the his Purkinje system, then that leads to a wider QRS, which is also called an aberrant QRS. We'll get to that in our tachycardia lecture. Now, the ventricular myocytes are the final pathway. So following depolarization of his Purkinje system, the electric impulse will relay to the myocytes, and this will conclude in contraction of the heart, of the ventricles, and the blood going towards the lungs and the rest of the body. There is important properties of cells within the heart. So cells within the sinus node, the AV node, and the His-Purkinje system, which is the electrical framework of the heart, exhibit nodal automaticity, or just automaticity, meaning that phase 4 of the action potential, there is auto-depolarization within the cells, which results in the action potential. And the rate of this auto-depolarization changes within the different portions of the conduction system. So the sinus node is usually the first to depolarize, and that's why it drives the heart rate. If there is suppression of the sinus node for whatever reason, then the AV node will take over, resulting in a junctional rhythm. This is usually slower than the sinus rate. But if this AV node does not take over, the His-Purkinje system will take over. So conductive cells of the heart exhibit nodal automaticity, which allows auto-depolarization and what we call an escape rhythm. So if the sinus node doesn't depolarize, the AV node will allow for an escape rhythm, and if it doesn't, the His-Purkinje system will allow for an escape rhythm. On the other hand, myocytes, so cells within the muscle, do not usually exhibit this auto-depolarization, and although they can supply escape rhythms, they are usually non-reliable. And in this case, you see that phase 4 of the action potential is quite flat, and it's usually nodal cells or His-Purkinje cells that drive the automatic nature of our conduction system. If you actually summarize all the signals within the heart, you get you get the signal we see on the electrocardiogram. So you see the sinus node exhibits auto-depolarization, the atrial myocytes do not. The AV node also exhibits automaticity, and so does the His-Purkinje system at different rates. And then the myocytes within the ventricles are responsible for most of the QRS potential. So if you add up all the electrical signals within the heart, you see what we have as the 12-lead ECG. And always remember that depolarization occurs from top to bottom and right to left. So first the atriums, right atrium, then left atrium, and then down to the ventricles. There are some main principles to the conduction system, and I'll try to explain it in this important slide. So first, the sinus node will depolarize, resulting in depolarization of the right atrium followed by the left atrium. And atrial depolarization is seen as the P wave on the QRS. Then there is a delay in the AV node like we discussed, and that results in the PR interval. The His-Purkinje system will lead to depolarization of both ventricles simultaneously, and you get the QRS, which is usually a narrow complex. There is then the ST segment, where there is muscular contraction which follows the QRS. So first there is electrical stimulation followed by muscular contraction, and then there is repolarization of the ventricles, which is seen as the T wave. So there is normal conduction is from top to bottom. There is the concept of overdrive suppression, meaning if the top fails, the bottom can escape. So if the sinus node does not depolarize, the AV node will take over, and if it does not, the His-Purkinje will take over, etc. Atrial depolarization is sequential, right atrium then left atrium, whereas ventricular depolarization is normally simultaneous. The right ventricle and left ventricle will depolarize together. This is Dr. William Einthoven showing the first electrocardiogram where buckets of electrolyte solutions were used to record electrical signals from the legs and the arms, and he used this exact structure to give us the limb leads on our ECG. So soaked his right hand and left hand in electrolyte solution and his foot, and using vectors between these structures, he was able to formulate the limb leads on ECG. And our ECG is very similar to what we use right now. Only now we have these electrodes that we can attach to the body, and it's a very convenient test. It takes a few minutes to obtain a 12-lead ECG, and for the quickness that we can do an ECG, we get a lot of important information, and it's vital to almost every patient that is admitted to the hospital. This is what a normal ECG looks like, and like I said initially, it's important to always look at a normal ECG and form an imprint within your mind so that when you see abnormal ECGs, they are easier to recognize. It is important to understand that within the leads on an ECG, negative complexes occur because the wave of depolarization is moving away from the lead, and positive complexes occur when the wave of depolarization is moving towards the lead. This is how the leads are usually placed, and it's important to understand this and know it so that each one of you can perform a 12-lead ECG on their own. So it's expected that every physician can place the leads on the chest in the right manner and on the limbs and be able to obtain a 12-lead ECG. V1 to V6 are placed in the precordium. V1 is on the right side of the sternum at the fourth intercostal space. V2 is on the left side of the sternum at the fourth intercostal space. And the sternal angle sits at the second intercostal space, and then you could count down to the fourth intercostal space. The rest of the precordium leads are placed according to the instructions over here, where V6 is placed at the mid-axillary line. The limb leads are placed exactly where they're labeled: the right arm, right leg, left leg. This shows the precordial leads, how they are positioned, and they're positioned around the heart so that we get a view of the right ventricle and the left ventricle. V1 really reflects the right ventricular depolarization because it sits next to it. V2 and V3 are more septal leads, whereas V5 and V6 are more towards the apex and lateral LV wall. The limb leads are obtained from the right arm, left arm, right leg, and left leg leads give us leads 1, 2, 3, AVF, AVR, and AVL, which are really vectors derived from these limb leads. So for example, lead 1 on the ECG is the vector from right arm to left arm. Lead 2 is the vector from the right arm to the left leg, and lead 3 is the vector from the left arm to the left leg. Now, there is an electrode placed on the right leg, which is usually a grounding electrode. And from these limb leads, we can also obtain the vectors that give us AVR, AVL, and AVF. So by placing right arm, and left leg leads, we're able to obtain 6 configurations on the ECG. Leads 1, 2, 3, AVR, AVL, and AVF. And this is what we're left with. We get a 360 view of the electrical depolarization within the heart. The precordial leads V1 to V6, and the limb leads 1, 2, 3, AVR, AVF, and AVL, and this allows us to see the direction in which electrical signals flow within the myocardium in almost 3-dimensional form. And we obtain what looks like a 12-lead ECG. So you see leads 1, 2, 3, AVR, AVL, AVF, and then V1 to V6. Now this is a normal ECG, which is what we call normal sinus rhythm. With normal sinus rhythm, the rhythm initially starts at the sinus node. So the P wave is positive in leads 1 and 2. And it's positive in leads 1 and 2 because it starts at the top right. So when you start at the top right and you move towards the bottom left, because you're moving towards the left, lead 1 is positive, and because you're moving from top to bottom, lead 2 is positive. So this is what we call a normal axis of the P wave. And it tells us that the electrical signal is coming from near the sinus node or from the sinus node. So a normal P wave axis is normal, which is 0 to 90 degrees. Each P wave is followed by a PR interval and then a QRS. The QRS axis is also usually normal, positive in 1 and 2. Each QRS is preceded by a P wave. So if each P wave is followed by QRS and each QRS is preceded by a P wave, then we know that there is a direct relationship between the atria and the ventricle. The PR interval is usually 120 to 200 milliseconds, and the rate is usually 60 to 100 beats per minute. If you satisfy all these criteria, then you have normal sinus rhythm, which is a normal ECG. Next part, we will discuss arrhythmia mechanisms for bradycardias and tachycardias, and here I will leave you with the breakdown of bradycardias and tachycardias, which we will go through in the upcoming lecture. Thank you very much.